TSH helps us determine or differentiate primary from central causes of hypothyroidism. In primary hypothyroidism, we expect TSH to increase because the pituitary compensates for low thyroid hormone. Conversely, in primary hyperthyroidism, elevated T3 and T4 suppress TSH through negative feedback. TSH levels reflect the pituitary's perception of circulating hormone levels, which is why it's such a powerful diagnostic marker. It's important that we recognize patterns in thyroid disease determination and diagnosis. A high TSH typically signals primary hypothyroidism, whereas low TSH points towards hyperthyroidism or central hypothyroidism. When interpreting TSH, you always correlate it with free T4. A mismatch, for example, low TSH with low T4, suggests pituitary or hypothalamic disease. Consistency across these values help pinpoint where the dysfunction lies in the hypothalamus pituitary thyroid axis. In central hyper or hypothyroidism, the pituitary or hypothalamus fails to respond to low thyroid hormone. So despite low T4, TRH, and TSH, levels remain low or inappropriately normal. This is a key reason why TSH cannot be used alone to diagnose hypothyroidism in patients with pituitary disease, trauma, or tumors, even in infiltrative conditions. Because if both T4 and TSH are low, your suspicion should shift away from the thyroid and actually move upward towards central regulatory organs. TSH secretion is governed primarily by circulating T3 and T4 levels via negative feedback. It does have a circadian rhythm with basal levels in the morning around 10 a.m. and peak levels at night, especially near 10 p.m. Clinically, this means TSH values can vary slightly depending on the time of day. Current evidence suggests that a TSH above 2 may represent early or subclinical hypothyroidism in some patients, although reference ranges still commonly list the upper limit of as 4. Normal adult TSA ranges, therefore, are at zero point 0.3 to 4, although some clinicians consider zero point 0.5 to 2 as the optional functional range. Many factors can alter TSH results, including recent radioisotope exposure, severe systemic illness, and diurnal variations. Certain meds can also interfere with pituitary thyroid signaling. Always confirm unexpected TSH findings with free T4 and, when appropriate, free T3 to avoid any misinterpretation. So what is normal? This is kind of giving us a picture of what is like the standard TSH distribution and kind of where that like median, mode, and mean occur versus where these outliers are and why we have that like zero point 0.5 to 4 as our typical reference range. Although sometimes you'll see this like zero point 0.5 to 2 as the optimal range. When I'm working with patients on fertility, I'm typically looking at a range between 1 and 2 as my goal range, especially if there's some challenges with fertility that I think potentially could be related to thyroid. A high TSH level is typically seen in primary hypothyroidism, thyroid ablation, excess iodine exposure, or congenital thyroid dysfunction. Low TSH levels occur in hyperthyroidism, secondary and tertiary hypothyroidism, and in cases of exogenous T4 use. These predictable patterns help clinicians narrow down the cause of thyroid dysfunction relatively quickly. And this is showing an example flow chart for how you could interpret a TSH value and looking at TSH values up top, and then based off of that, what your free T4 level looks like, and then based off of that, what would be potentially your diagnosis or if there's further workup needed. This is looking at different types of TSH glycoforms, the majority of what that would look like in from the pituitary gland versus what this could look like in a hypothyroid state.